Okay, so let's look at what I perceive to be the more enjoyable aspect of this lecture. Not that I don't enjoy MRI physics, but let's be honest, it can be a little bit taxing. So we're going to be looking at the role that MRI plays in the oncology patient pathway, and we'll look at some specific cancers and their appearance on different sequences. So MRI basically plays quite an important role, as you can imagine. Obviously, it's cross-sectional imaging, and it can allow us to image the body in different planes. We can actually do whole body MRI imaging, which we will talk about towards the end of this lecture. One of its great benefits is that it doesn't involve any ionizing radiation. I mean, obviously you know that, but it's just really important to emphasize that, especially when you're talking about whole body imaging or when you're talking about pediatric imaging. But essentially MRI is used in lots of different ways when it comes to an oncology patient. So it can be used to detect the tumour, it can be used to stage the tumour, it can be used to monitor the patient's response to treatment, potentially if the patient has a relapse, and it can also be used to restage. So one of the big things about MRI really in oncology is that it's an excellent problem solving tool. And what I mean is quite often other imaging modalities are used in the first instance. So for example, ultrasound or CT, and quite often MRI will be recommended to be used if they are trying to ascertain, has this tumour spread? Is there nodal involvement? Is this tumour multifocal and multicentral? We'll come to that as well. So it is a really good problem solving tool, and it's a great tool to use if other imaging modalities haven't given definitive answers. But obviously it does have some challenges. Now we all know that there's safety contraindications. I'm not going to go into that, but all patients obviously have to have a safety checklist filled out before they get any imaging. Also, it can be quite claustrophobic, so patients can really struggle with having MRI scans, although oncology patients, I can't speak for all of them, but they do tend to be a little bit more they know that they have to get the scan done essentially. There's also the use of gadolinium, which, gadolinium is a safe contrast agent, but, there is some side effects, and there's nephrogenic systemic fibrosis, which you would have covered in AI, and that can really be very dangerous for patients who have got severe kidney problems. And there is also gadolinium toxicity. So there has been studies that show that gadolinium, is still deposited in your brain, or can be many years later. So the use of gadolinium, although very vastly safe for the majority of people, for those people who have got severe kidney problems, it can definitely be an issue, and that's why we make sure that we check patients' glomerular filtration rate. We also have challenges such as respiratory and cardiovascular motion. So these are not challenges that are specific to oncology, they're just challenges that are specific to MRI in general. But breathing is definitely an issue in MRI, as is cardiovascular motion, although we can use gating and techniques to lower the impact that has on the quality of the scan. Some of the sequences that we use most often in oncology are T1 sequences. So T1 sequences tend to have a short repetition time and a short echo time. And very basically, fluid is dark on a T1. Okay, so that's one of the sort of basic understandings, without getting into too complicated, that fluid is dark on a T1. We also use T2 sequences, which tend to have a longer repetition time, a longer echo time, and again, basic sort of MRI would be that fluid is bright on a T2. Going into the more complicated ones, so we have the fluid attenuated inversion recovery sequence, which is known as a FLAIR, where we suppress the fluid and it appears dark on the image, so it will remove any sort of cerebrospinal fluid or any fluid anywhere else in the body. We also use the stir quite a lot in MRI oncology, so it's known as the short T1 inversion recovery, and that suppresses the fat in the body, which is really good for looking for malignancy. And the fat appears dark. And the other sequence that we use is the diffusion weighted imaging sequence, okay, which essentially measures the movement of water molecules within the body, so the Brownian motion of water molecules. And if there is a pathology, and in this case we're talking about oncology, so if there is a tumour, usually that will restrict the movement of water, so we have restricted diffusion, and then that will be obvious on the sequence. So these are the main sequences we use. There are many other sequences in MRI, but we have to sort of narrow down when we're teaching you about this. So we've identified these 5 sequences as the main ones that are used in oncology imaging. So the first cancer that we're going to look at is prostate cancer. Okay, so prostate cancer is one of the most prevalent cancers in the UK, and it is the most prevalent cancer in men. And symptoms really depend on the extent of the tumour. Okay, so some men will present having urinary disturbance, so not able to empty their bladder, or they're struggling to empty their bladder. They may have blood in their urine, or they may have back pain because the cancer has started to spread. They may also have an elevated prostate-specific antigen test, okay? So anything greater than 4 on that test would be suspicious of a prostate cancer. And these patients may have a digital rectal exam when they're at the GP, or if they get referred as an outpatient to the hospital. And when they are diagnosed with a prostate cancer, they use a Gleason score to grade the cancer. So remember we talked about grading being, just how cancerous is the tumour, so how fast moving, or not fast moving, but how quickly are the cells dividing, and how aggressive is this cancer, and they use the Gleason score to do that in prostate cancer. Now, one of the, sorry, my dog's barking. One of the imaging modalities that can be used in prostate cancer is transrectal ultrasound. But in 2017, MRI started to become a much more essential tool prior to biopsy. Okay, so MRI plays a big role in imaging prostate cancer. So the image on your right hand side, or actually is it your left hand side? Your right hand side, you'll see that this is the prostate gland here, and you can see PZ stands for the peripheral zone, and the CG stands for the central gland. Okay, now about 75 to 80% of tumours are usually in the peripheral zone, and central gland tumours can be really difficult to biopsy just because of where they are. So this is where MRI comes into place. It can really help with that as well. So we'll have a little look. So in terms of who should be imaged with MRI so any symptomatic patients should receive MRI, because it really has a good contributing role in determining the extent of the tumour, any associated complications. It's good for planning treatment, for planning biopsy. Also, any patients who are considered at high risk of metastatic disease, so if they've got a high Gleason score, then they would absolutely get an MRI scan to ascertain any evidence of metastases. Patients who are potential surgery candidates, so you may or you may not know there are different routes to go down for prostate cancer. There's radiotherapy, there's surgery, there's hormonal treatments, there's a combination of all. So patients who are potential surgery candidates would have an MRI scan to just look at see if there's any extra prostatic disease, essentially. Patients who have got palpable tumours, and then also patients who are considered low risk, so maybe their Gleason score is quite low and they're not considered to have an aggressive tumour, but they are under some surveillance, so it might be that they're not having any treatment. And this sometimes can happen for patients who are a lot older, that actually they think that the kind of risks outweigh the benefits, or the side effects would outweigh the benefits, because the patients are already maybe 80, 90 years old, or whatever it might be. So these are the kind of men who will be imaged by MRI who've got prostate cancer. And really, part of the staging is to determine the extent of the disease, and also to ascertain really, is the tumour confined to the prostate, or is there actually tumour extending out of the prostate, so extra prostatic disease. We also want to look at those lymph nodes around the prostate to determine whether or not there's any involvement, because we know from previous lectures that lymph node involvement means that it's more likely to be aggressive, it's more likely to spread, and means that the patient might need chemotherapy. And also to look at the presence of any bone metastases, so looking at the hips, looking at the pelvis to see if there's any presence of bone mets. And also an important thing to look at is whether or not there's any urinary tract obstruction as well, because that means that the tumour has, went out the confinements of the prostate. So there is a particular protocol that is used. Usually they're carried out obviously in a 1.5, sometimes a 3T scanner, and we would use the pelvic body coil or an endorectal coil. So you can see this image on your right hand side. You've probably maybe seen this when you're out in MRI on placement, that the patient will have it over their pelvis area, make sure it's up to the crests, and the patient is usually supine. They can go in feet first, they can go in head first, usually feet first, but it does really just depend on where you're working. Okay, so the protocol that we use. So the patient gets imaged in 3 planes for a T2, and it's quite a small field of view because we want to have nice resolution. And what they're looking at in those coronal and axial and sagittal T2 images is really just for local staging. So is the tumour contained within the prostate? Which part of the prostate? Is it in the peripheral zone? Is it in the central gland? Is there any nodal involvement? Is there any kind of seminal vesicle invasion? So that's what we're looking at with those T2 3-plane images. We'll then also do an axial T1, and that's to look really for the outline of the gland and if there's any blood within the prostate, so any bleeding. We'll have a coronal T1 pelvis and abdomen to look for any other nodal involvement, any evidence of metastatic disease. And then we'll have a DWI, so that diffusion weighted MRI sequence, to look for the extent of the tumour, and then also to see if there's any extra prostatic disease as well. And one of the important things that we do for the prostate MRI protocol is something called dynamic contrast enhancement. So you might have heard of this before, or you might not have, and it's carried out quite often in certain oncology patients, and I'll just tell you a little bit about that on the next slide. So basically we're using the normal contrast, so the normal gadolinium that we would use in other patients. So obviously, remember we talked about this last week, gadolinium is what we use in MRI for contrast. But what we do is we take advantage of the differences in vascularity which are in tumours compared to normal tissues. Okay, so tumours are more vascular than normal tissues. So using dynamic contrast enhancement, we're taking advantage of those differences to try and determine whether or not a lesion is malignant, and also maybe how malignant it might be. So we're looking at the uptake, so meaning the absorption of the contrast in the tumour, and then the washout, so meaning when it passes through. That's what we're looking at, because in cancers that are in tumours that are malignant, the uptake and the washout is much more rapid, so much quicker than it would be in a normal tissue. Okay. We use the term dynamic because we're using multiple images before, during, and after the injection of the contrast. Okay, so we're using kind of serial images that are showing us how quickly did the tumour uptake the contrast, and then how quickly did the tumour wash out the contrast. Okay, and the quicker it does that, the more likely it is to be malignant, and also you can try and determine how malignant it might be as well. So looking at the protocol for dynamic contrast enhanced prostate scanning, we take multiple T1 images before, during and after we inject the contrast. I said before, it's gadolinium based, and then we're scanning for roughly between 4 and 8 minutes. It might depend on the site that you work at. And we watch as the injected contrast passes from the arteries into the tissue microvascular, and then we watch as it extravasates within seconds into the extracellular space. Okay, so we're watching essentially it going into the tumour, how quickly does it go in, and then it coming out of the tumour, how quickly does it leave. And malignant lesions do tend to show earlier and faster enhancement than non-malignant lesions. Okay, so that's why it's so helpful in determining if something's malignant or not. And the reason why tumours enhance differently to normal tissue is because when you have a cancer, the tumour results in I can't say this word, angiogenesis, which basically means a physiological process happens that the tumour starts to create vessels. Okay, so you have more vessels than a normal healthy tissue. Okay, and then also the permeability of those vessels is increased as well, which means that it's allowing things to flow, okay, out of the vessels. So drugs, nutrients, water, contrast, okay, they become more permeable in these abnormal cancerous tumours. Therefore, they absorb the contrast quicker and they'll let the contrast go out as well. So that's why tumours are enhancing differently to normal tissue, because we've got more vessels, and these vessels allow for the flow of contrast much more easily than the normal tissues. Okay, so looking at some of the images for the prostate cancer, this is a T2 image, and you can see that there is high signal in the peripheral zone, which is normal. Okay, so this is normal. And then on a T2 weighted image, a prostate cancer generally is low signal, so it's hypo-intense. You can see where the arrows are pointing to, that there's two tumours, and they are hypo-intense, so they are low signal. On the DWI, it will show restricted areas of diffusion. Okay, so these are both DWI, they look slightly different because they've got different B values, but we're not going to go into that. So on both images, you can see that the tumour, where the green arrows are pointing, are showing areas of restricted diffusion, and on the DWI, it appears bright. Okay, now one of the problems with DWI is that they're really susceptible to artifacts. So if a patient had a hip replacement, you wouldn't be able to carry out this sequence because it would just distort the image too much. But this patient doesn't have a hip replacement, so you can quite clearly see that there is an area of restricted diffusion, and that appears bright on the DWI image, okay, on both sides. So it's a different patient, but they both got cancers in quite a similar area. Okay, so one time there'll be a place to put my face that's not in the way of a picture. This example shows another cancer, so T2 and DWI, and you can see the correlation. So on the T2 image, it's hypo-intense, so it's got lower signal. And then on the DWI, it's brighter because there's an area of restricted diffusion, okay, and it's in the peripheral zone. Okay, so that is how prostate cancer appears on different sequences on MRI. We're now going to go on to cervical cancer and how that appears on MRI. So cervical cancer is the third most common gynecological malignancy after endometrial cancer and ovarian cancer, and it's much more common in women who are, so young women, I like to say that, aged 30 to 34 years. All right, so you know, all of us women will know that we go and get our smear test every 3 years to make sure that we don't have any precancerous cells. And that's one of the amazing things about the NHS, is that we have that screening programme to help prevent or to treat early these cervical cancers. Now, there's different symptoms associated with cervical cancer. The main one is vaginal bleeding or discharge. And there are some risk factors. So if you have the HPV virus, which is a very common virus, but if you have the particular type HPV 16 or 18, then you are more at risk of getting carcinoma of the cervical cancer. It doesn't mean that you will get it, but it means you're more at risk. And I think kids these days get the HPV vaccine, which is fantastic, but in my day, and probably in some of your days, we didn't get that option. So it can cause cervical cancer. Other risk factors are if you're immunosuppressed. So if you have, if you're on immunosuppressants, or if you have HIV that's not, well controlled with therapy, which thank goodness these days HIV can be so well managed and people are so healthy and live a long life. But if not, then you can be more at risk of cervical cancer. And then lack of engagement with screening. So, some people still do not attend for their screening, which is just such a shame because it is such an amazing way to prevent, because you can have these precancerous cells, or to identify earlier cervical cancers. So that's who might be more high risk at getting cervical cancer. In the first instance, ultrasound would be used, so transvaginal ultrasound, and then MRI would be used for staging, okay? And that's quite common with a lot of cancers that we're talking about, is that MRI is not really the first first modality, because maybe ultrasound or CT is quicker, but quite often once something is identified, patients will then go on to have an MRI scan for more detail. So who needs to be imaged in the case of cervical cancer? So essentially all women who have had a cytologically proven cervical cancer. So what we mean by that is that they have had a smear test and it's shown that there are cells that are suspicious of malignancy. So they all need to be imaged with MRI. And all patients need to be staged as well. And then any patients who are maybe going through treatment and they have to be monitored in terms of their response to treatment, they'll have MRIs throughout. And then patients who are in remission and then have to be followed up. So MRI plays quite a big role in the imaging of women with cervical cancer. And the objectives of the staging is firstly just to assess, well, how big is this tumour? And then we have to consider, has the tumour spread into any of the surrounding structures, okay? So is there any other involvement of the bladder, the vagina, or the rectum? And then, like all the cancers that we talk about, we want to know if there is any nodal involvement, because we know that nodal involvement means not as good a prognosis, or it might mean that you need more aggressive treatment. And then we want to look and see if there's any distant metastases as well. So we're looking for pelvic nodes, abdominal nodes, and then any metastases as well. So the protocol that we use in MRI for a cervical patient, again, usually 1.5 or 3T scanner, and we're using the body coil, pelvis coil, really lying over the patient. The patient generally would be supine, but can change obviously if you can put them in head first if you want, but it would be much better for the patient to put them in feet first, because then their head's not going in as far into the bore of the magnet. And then the sequences that we carry out are a T1 axial with a large field of view. So we want to look at, if there's any, we'll just want an overview essentially of the pelvis area. We'll look at any nodal involvement. And then we'll have a T2 axial, and it's still got the whole pelvis on it as well, to again get that sort of anatomical overview. And then we'll have T2 sagittals and T2 obliques. Okay, so the T2 sagittals are really good for assessing the position of the tumour, seeing how it is in relation to the external organs, again looking for any vaginal or rectal involvement. And the same for the T2 oblique. It's really good for assessing the size of the tumour and any other involvement. And then we will do a T1 fat sat, so we'll suppress the fat, which is quite similar to a stir. It's just a different technique for suppressing fat. And we'll administer contrast, and we will image to look for, again, enhancement. How does the tumour enhance? Is there any other areas of enhancement which would suggest that there's some spread? Okay, so they're the cervical MRI protocols that are carried out. But again, I have to say, lots of places do things differently, so there might be slight tweaks, but these are the more commonly carried out sequences for this malignancy. Okay, so on this image you can see that there is a sagittal on the left and there is an axial on the right. We know that they're T2 because the fluid in the bladder is bright. Okay, now you can see that there is a tumour. So up here you can see this is the cervix, and this mass here, so it's heterogeneous, basically it's mixed signal, but it is hyper intense compared to the normal cervix. Okay, so we would describe this as a hyper intense mass in comparison to the normal cervix, and it has got a mixed signal. And you can see over in the axial it's the same. It's hyper intense when compared to the normal cervical tissue. If you look at the T1 with contrast, it's important to note that we don't always have to use contrast, but it can be used to help differentiate between cervical and endometrial cancers. Tumours are, will enhance and they will be hyper intense. So you can see here that there is a T2, a lesion basically, on the T1 with contrast, and there is invasion as well of the vagina. So we sometimes will use the dynamic contrast enhanced technique as well, as I said, to help differentiate between cervical and endometrial cancers. So looking at the uptake and looking at the washout of the contrast, or sometimes we won't use contrast at all, very dependent on the local protocols. Okay, so that is cervical cancer on MRI. You can see this mass here. And we'll move on to breast cancer on MRI. So breast cancer is the most common cancer in the UK. So about 150 people a day are diagnosed with it. And the very vast majority are women, although men can get it as well. And some of the symptoms are a lump, thickening of the breast tissue, discharge, any sort of change or size, shape, of the breast would be considered a symptom. And there are really preventable risk factors when it comes to breast cancer. So things like obesity, alcohol, like a high alcohol intake, or being inactive can increase your risk of breast cancer. But the vast majority are non-preventable. So things like your genetics, you might have heard of the BRCA gene. So if you have that, you're more likely to get breast cancer. The older you are, you're more likely to get breast cancer, but obviously it doesn't always have to be in older women. Your hormone levels, so if you have higher levels of estrogen, you're potentially more likely to get it, because some breast cancers feed off estrogen. The denser your breast tissues, and also not having children. So there are studies to show that if you have your children later in life, or you don't have any children, then you're at a slight increased risk of getting breast cancer. But all of these do not mean that you will get breast cancer. It just means that you might have a slight increased risk of getting it. In the first line of imaging, we know that we use mammography and we also use ultrasound, but MRI is also used in certain cases as well. So when MRI is used, it doesn't tend to be used in the initial staging or the initial diagnosis, but it can alter the stage of the patient's breast cancer. And when it's really useful to use is to determine whether or not the breast cancer is multifocal or is multicentric. And what we mean by that is it contained within the same quadrant of the breast, or is it in multiple quadrants of the breast? Okay. So it's really important to determine that, and we'll come on to why that is the case in a minute. We also need to utilise MRI in breast cancer when there's breast cancer cells somewhere else, but they've not noticed or not seen a mass on a mammogram. So some patients sadly are diagnosed when they've got back pain or abdominal pain, and they turn out to have a tumour in their bones or in their back or in their liver, and when they biopsy and they look at the cells under the microscope, they're breast cancer cells. And it could be that they don't see a mass on the mammogram. I know of one person that I met along the way of my diagnosis who this did happen to, and they never they couldn't see the mass on the mammogram, but then when they did the MRI they could see a very, very small mass. So these are the type of patients that would have to be imaged in MRI, because MRI is the most sensitive method of detecting breast cancer, and that's why these patients would come and have an MRI scan. Other patients who would have an MRI would be those with dense breasts, so it tends to be younger women, because dense breasts are harder to image on mammography. And then patients who are having neoadjuvant chemotherapy, so patients who are having chemotherapy before their surgery, and they would do an MRI to monitor the response to treatment. So you might have your first part of your chemotherapy, and then you maybe have an MRI to see how you responded to the first part of it. In terms of the protocol, so again, 1.5 or 3T scanner, we do have these dedicated breast coils, and the patient is prone, so they're lying on their front. You can go in head first, you can go in feet first. Again, it depends which site you're working at, but the image shows it quite well. So the patient is prone and their breasts are sitting in the dedicated breast coil. And we have a few scans that we carry out, starting with the axial T1, and then we do an axial T2, and then we'll utilise that dynamic contrast enhancement again using gadolinium and carry out a T1 fat-sat axial. So we'll look at some of the images. So this is a T2 appearance of breast cancer, and you can see the cancer just here within the breast. And on T2, breast cancer tends to be hypo-intense, so darker, less signal compared to the surrounding structures. And then when you look at it on a T1 fat-sat, you can see that it's hyper intense, so it's got more signal when you compare it to the surrounding structures. So this is a fat-satted image. Again, fat-sat is similar to stir in that the fat is suppressed. It's just a different way of doing it. Obviously our breasts are made up with a lot of fat, it's fatty tissue, and you can see that they've suppressed all this fat, and you can see that there's this lobulated mass with irregular margins, is how you describe this. So lobulated, irregular margins, it's in the lobules of the breast, and it's hyper intense compared to the surrounding structures. And then if we look at it with the dynamic contrast enhancement, this again is a T1 fat-sat, so the fat has all been saturated, but we have obviously introduced this contrast, and you can see that there's homogeneous enhancement, so there's homogeneity enhancement the whole way through the tumour. So it's the same patient, they've got a lobulated mass with homogeneous enhancement. Now, one of the reasons, and I said I'd go back to this, why it's so important to carry out MRIs sometimes on women with breast cancer is because you want to know whether or not the cancer is multifocal or multicentric. Okay, so if it's multifocal, then it's in the same quadrant of the breast. If it's multicentric, then that means that it's in different quadrants of the breast. Now, if it's in different quadrants of the breast, that very much can determine the type of surgery a patient will go on to have. So patients who have multicentric disease, meaning in different areas, different quadrants of the breast, are more likely to opt to have a mastectomy. Okay, so sometimes what will happen is you'll have your ultrasound scans. You can see on this one there is, this is an ultrasound on the left hand side, and there's these lesions that are seen, but it's not exactly clear if they're all in the same quadrant or they're in different quadrants of the breast. So they've gone on and had this MRI, which shows that there is, this is a sagittal contrast enhanced MRI, and you can see that there is two separate cancers in the breast. So this patient is much more likely to go on and have a mastectomy instead of having a lumpectomy, which is the other option where you just remove part of the tissue from the breast where the breast cancer is, but you don't remove the whole breast. So that's why it's so important in breast MRI because it can actually dictate the type of surgery that the patient goes on to have, which is a massive thing for a woman, whether they're going to, have a lumpectomy or they're going to have, a bilateral or unilateral mastectomy. Okay, so moving on to the last part of the lecture, which is whole body MRI in oncology. So MRI is really obviously an attractive modality. It's highly sensitive. There's high soft tissue contrast, and there's the absence of ionizing radiation. So naturally, people have considered its role in imaging the whole body. But really only in the last 10 years has it become more common, because it used to take such a long time, and it used to be that MRI was less available, but that's not really the case anymore. It's highly available, and it takes less time now. So there has been marked progress in the last 10 years of using whole body MRI in oncology, and it gets used in research quite a lot, but it does also get used just in clinical practice now. It's really good for tumour detection, looking at sort of bony nodes, bony and nodal metastases and nodal involvement. And the big field of view means that we can image the patient from head to toe. So it's good for detection, it's good for staging. And one thing it does get used for, probably more in America than here, is for screening as well. Not a national screening program, but a patient opting to have a full body MRI to screen for any disease. So in terms of the clinical application, we're looking at hematological cancers, so Hodgkin's lymphoma, non-Hodgkin's lymphoma, multiple myeloma. These patients could get whole body MRIs. Now, at the moment, they're more likely to get whole body CTs and PET CTs, but more and more, especially for multiple myeloma, they're getting whole body MRI scans. It's also good for neuroendocrine tumours, and very much gets utilised in the paediatric setting. Now, the other lecture this week is for Pediatric Oncology, so you'll see me talk about whole body MRI a little bit more in that. And again, as I said, private screening, but that's not offered on the NHS. In terms of protocol, usually again 1.5 or 3T scanner, and we basically utilise all the coils, so head, neck, body, peripheral coils. You can see this image here, so this is the patient's head up here in the Siemens scanner. Then they'll have this sort of smaller phased array coil that's sitting over the patient's shoulders and chest, and then they've also got on the body coils, and then they've got what we call a peripheral coil that sort of slides up in between the legs. So they're basically covered from head to feet. And we carry out a whole body coronal T1. We also carry out a whole body coronal stir, so that's fat suppression, and then also a whole body diffusion weighted image. We don't tend to use contrast unless it's getting done in conjunction with, say, a dedicated abdominal MRI where they want to look at maybe the vascularity of a tumour, and then in that case they would carry out the whole body first, and then they would do the separate MRI of the abdomen. The patients always are supine as well and tend to go in head first. So here you can see a whole body MRI on a patient that has lymphoma. So this is the T1 here, so the fluid is dark, and we can see that they've got this mass in their neck. They've got, nodes down here as well, so aningual nodes as well, mediastinal nodes. And on the T1, the nodes are hypointense, so they've got low signal compared to the surrounding structures. This is the coronal stir. So all the fat has been suppressed. So it's really good because you can see how bright, this isn't fat, it's not a fatty tumour, because if it was, it would be suppressed along with all the other fat. So this patient has got hyperintense signal on the stir in their nodes, which is highly suspicious of lymphoma. And this one here is a diffusion, but don't worry if you're a bit confused by it, because we don't normally see them in the coronal plane. but in whole body we do construct them into the coronal plane. And we also do something called inverting them. So it's almost like sometimes when you can invert pictures on your phone. So we invert them and we can see that there is areas of restricted diffusion, which shows as really dark areas that correlate with the lymph nodes on the STIR and the lymph nodes on the T1. So there's restricted diffusion here, there's restricted diffusion down here in the groin lymph nodes. So yeah, so that would be highly suspicious of lymphoma, and a biopsy would be taken to determine what type of lymphoma. So lastly, we'll finish up with MRI whole body screening. So in the UK, you can get one if you want one. It's going to cost you about £350 and only really gets offered by private healthcare providers. So what they do is they'll image your brain looking for any hemorrhage, any benign or malignant tumours, infections, you know, anything that could be going on. And then the same for the abdomen and the pelvis. So looking at all the organs and looking for enlargement of any lymph glands, any benign or malignant tumours as well. But there are things obviously to take into consideration for any screening, especially when it's a screening that's not offered by the NHS. And it's really important to remember that MRI is highly, highly sensitive. So there is high rates of false positives, and they can have extremely, extremely profound impacts on a person's mental health. So to be told that you have something that actually isn't going to ever turn out to do you any harm could really take its toll on you. To be told that you've got something and actually it's incorrect, you know, it's actually a cyst, it's not a tumour or whatever it might be, can really impact the patient as well. And it's also important to know that it is expensive, and it really is just looking more at the anatomy as opposed to, you know, when we talk about PET-CT, looking at things at more of a molecular level. In whole body MRI, it's really just an overview of the patient's anatomy and looking for any tumours, okay? And it's important to remember, like all screening, it's just screening the here and now. So a patient could have a whole body MRI and then a year later could have developed a cancer. So that's an important thing to remember as well. One good thing, I suppose, about whole body MRI screening would be if someone is in a high risk group. So some patients do have genes that mean that they are more predisposed to cancer, and not just say the BRCA gene with breast cancer. Some people do have genes where they're more predisposed to lots of different types of cancers. So it could be that whole body MRI screening is of benefit to them. Okay, so to summarise, because I appreciate this has been quite a long lecture and you do have other lectures to look at this week. So MRI really does play an important role in the patient's pathway, but it's often in addition to other imaging modalities. So it's not always the first port of call, much more so in paediatrics it is, but in adults, ultrasound, CT, even X-ray might be the first imaging modality that the patient undertakes, but then they'll get referred to MRI for more detail, because really MRI is known as an excellent problem solver. So if they want to know, is there nodal involvement? Do they want to know if there's you know, other organ involvement? Do they want to know if it's multicentric, multifocal, whatever it might be? MRI is a really good problem solver and can help clinicians answer that question, which then in turn has an impact on the patient's pathway. So whether they're going to have surgery, chemo, what type of treatment they're going to have. Dynamic contrast enhancement also plays a really important role within MRI and oncology. So really looking at how quickly the tumour uptakes the contrast and how quickly it washes out the contrast can help you know, answer these questions that we're talking about if they're trying to figure out certain things about the cancer, the type of cancer, the aggressiveness of the cancer, all that kind of thing. Dynamic contrast enhancement can play a role in that. But we also have to be mindful that MRI is more costly and can be more time consuming. And we also have to consider MRI safety and the contraindications that come with it. Okay, so thanks very much. I know you've got a couple of other lectures to watch this week, so hopefully that wasn't too full on. And I'll see you all at the tutorial. Bye!